Today I'll be presenting my evidence-based practice topic analysis on hoarding disorder. I'll start with a brief overview of the diagnosis, including symptoms, prevalence, and how long hoarding impacts individuals, families, and communities. Then I'll walk through the intervention list I developed during the semester, focusing on two promising approaches social workers can implement in practice: multidisciplinary, community-based interventions, and home-based harm reduction. I'll end with a summary of the knowledge gaps that still exist in the research. Hoarding disorder is a chronic condition defined by persistent and difficult discarding possessions due to emotional attachment, fear, or avoidance. People with hoarding disorder often feel intense anxiety when facing the idea of letting go of items, even those with little objective value. This leads to the accumulation of clutter that overwhelms living spaces and interferes with daily functioning. Many individuals experience strong emotional meaning connected to their belongings. Items can represent safety, identity, memories, or future potential. Because discarding feels risky or deeply distressing, avoidance becomes the primary coping strategy, reinforcing the cycle of hoarding. Hoarding disorder is more common than many people realize, affecting an estimated 2 to 6% of the population. Rates tend to increase with age, especially among older adults who have accumulated possessions over decades. Hoarding is also more common among individuals who live alone, those with medical or cognitive challenges, and people with trauma histories. We also see associations with anxiety, depression, and ADHD, particularly with cognitive patterns involving difficulty organizing, making decisions, or managing emotional distress. Symptoms usually develop gradually and become more severe with age. Many people report that hoarding behaviors began in adolescence but weren't recognized until later adulthood, which means a lot of cases remain undetected for years. The impact of hoarding disorder reaches far beyond clutter. For individuals, hoarding can make cooking, cleaning, sleeping, and safe mobility extremely difficult. Homes often present fire hazards, fall risk, unsanitary conditions, or structural strain. Many individuals face eviction, adult protective service involvement, or loss of housing entirely. Family may experience stress, frustration, and conflict, and relationships that become toxic and strained and distant due to shame and secrecy. At the community level, hoarding can affect neighbors, building safety, and emergency responders. Overall, the disorder significantly impacts health, safety, social functioning, and overall quality of life. During my review of the literature, I categorized interventions into 3 groups: effective, promising, and not effective. Cognitive behavioral therapy with hoarding and motivational interviewing combined with cognitive behavioral therapy and hoarding had the strongest empirical evidence and support and fell under effective. Promising approaches include multidisciplinary and community-based interventions, and neurotransstimulation approaches like TMS or ECT, and some newer studies on compassion-focused therapy have been found. Finally, interventions shown to be ineffective and included medication alone and forced cleanouts show that they both fail to address the emotional and behavioral mechanisms that maintain hoarding and are not an effective therapy towards hoarding disorder. The first intervention I'm highlighting is multidisciplinary community-based intervention. This approach is essential for moderate to severe cases where safety risks are present. A multidisciplinary response brings together social workers, case managers, maybe a fire department, housing inspectors, public health staff, and mental health professionals to address both environmental and emotional needs of the client. Instead of relying on sudden or traumatic cleanouts, the focus is on harm reduction, stabilization, and maintaining the client's autonomy. For example, the team might address blocked exits or sanitation issues, while the social worker begins therapeutic engagement aimed at reducing avoidance and shame. These teams conduct a safety assessment to identify immediate risk, such as fire hazard, mold, infestation, or fall risk, and they prioritize the interventions accordingly. For the level of evidence of a multidisciplinary intervention, such as community-based interventions, are considered level B evidence for hoarding disorder, meaning they have promising support from real-world studies but fewer controlled trials compared to CBT-based approaches. Most of the evidence we have comes from community task forces, program evaluations, and case series. For example, evaluations of hoarding task forces in cities like Boston and Vancouver show that when fire departments, housing inspectors, mental health providers, and social workers collaborate, they see consistent reduction in safety risk, including blocked exits, fire hazards, and severe sanitation problems. These teams are also associated with lower eviction rates and fewer repeated referrals to APS. Another key finding in the literature is increased in client engagement. People who are overwhelmed or distrustful of formal treatment often respond better when multiple agencies communicate with one another and present a unified supportive approach. This collaborative model helps reduce shame and prevents individuals from becoming shut down or avoidant, which is common in hoarding disorder. Even though this body of evidence is strong in practical settings, it is labeled level B because we still lack large, randomized controlled trials. However, the consistency of results across many communities and the strong alignment with harm reduction and social work values supports multidisciplinary intervention as a promising approach for moderate to severe hoarding. Overall, multidisciplinary responses are evidence-informed, effective for improvising safety, and highly relevant for social workers who are coordinating across systems. The second intervention I'm highlighting is home-based harm reduction. This is a highly practical, social work-centered approach that focuses on safety, stabilization, and engagement for individuals living in severe clutter. Unlike forced cleanouts, which tend to traumatize clients and usually lead to rapid relapse, home-based harm reduction is collaborative, client-centered. The goal is not to get the perfect unsafe pathways, sanitation concerns, structural risk, and areas that prevent essential activities like cooking or sleeping. From there, the social work directly works with the client inside the home to set small, achievable goals. Examples might include clearing out one pathway and opening up access to a bathroom or creating a safe place to sleep. A key part of this model intervention is motivational interviewing. Many clients with hoarding disorder experience intense shame and avoidance, so MI helps the client explore their own values. The work is done slowly and respectfully at a pace that the client can tolerate. Small wins build trust, and over time, the client tends to be more willing to engage in additional sorting or decluttering tasks. Evidence for home-based harm reduction is level BC, with having evidence but limited studies. Studies of community hoarding task forces, such as those described by Tompkins, show that home-based collaborative work leads to meaningful reductions in safety risk, including fire hazards, unsanitary conditions, and blocked pathways. These programs also report lower eviction rates, fewer APS referrals, and decreased emergency calls compared to situations where individuals are given sudden and mandatory cleanouts. Another important finding is increased in client engagement. When people feel respected and supported rather than judged and threatened, they're much more likely to participate in ongoing care. Many clients who refuse CBT or drop out of office-based treatment will engage when the work is done in their home environment and focus first on safety. Home-based harm reduction is also a strong fit for social work practice because it emphasizes harm reduction, autonomy, dignity, and trauma-informed care and housing stability. It acknowledges that hoarding disorder is chronic and that safety improvements can significantly increase a person's quality of life, even if full symptom remission isn't immediately achievable. Across the research, several clear knowledge gaps remain. First, there's a lack of randomized control trials on non-CBT interventions, including both multidisciplinary models and home-based harm reduction models. Second, we need a more long-term outcome data because hoarding is a chronic condition and most existing studies follow clients for only a few months. Third, trauma and grief are commonly underlying contributors, yet hoarding interventions do not integrate trauma-informed frameworks or adaptations for neurodivergence. Fourth, culturally responsive research is extremely limited, and we need a better understanding of how hoarding presents across diverse populations, housing situations, and cultural norms. Finally, there is a strong need for integrated models. In conclusion, hoarding disorder is a complex condition that requires compassionate, multifaceted interventions. While CBT remains the strongest evidence based treatment, social workers play a critical role in implementing promising, practical approaches like multidisciplinary community based models and harm reduction models. By addressing safety risk, avoidance, shame, and environmental barriers simultaneously, we can help clients move towards safer homes, stronger relationships, and meaningful recovery. Thank you.